Hi, in this lecture, we are going to wrap up the urinary system by looking at diuresis, which is basically urination. We'll talk a little bit about the characteristics of urine, abnormal and normal things in your urine, and then we'll wrap it up with a few clinical application pieces. So when you hear diuresis, it's just the elimination of urine. You know that a diuretic is something that makes you urinate more, and urine is a lot of water. So when we're talking about diuresis, it usually implies a lot of urine is being produced. So the diuretic are the medications that cause you to lose more water in your urine. So remember, if you lose water in your urine, water's leaving your body. And so what that means is that your blood volume should decrease. And therefore, if your blood volume goes down, so does your blood pressure, which is why they're often used. They could also be used if you have a lot of swelling or edema and they're trying to pull that fluid out of circulation. Now, when we look at diuretics, the main type that we look at is one called Lasix, which is called a loop diuretic. There are other types of diuretics, but we'll just look at Lasix for a minute. So it's called a loop diuretic because what it does is it actually works in the ascending limb of the loop of Henle or nephron loop, and it blocks these little sodium transporters. And so what happens is it doesn't let sodium leave. Well, remember that those salts are what are keeping that medulla hypertonic. So if you don't pump out all that sodium, then you can't concentrate your urine as much. So your medulla interstitial fluid might be, around 900. Well, as the urine is coming out, right, as the filtrate is coming out, normally what you do when you open all those aquaporins is water leaves until you make it equal. The filtrate becomes equal with whatever the medulla is, so it could actually reach 1200 and be highly concentrated. Well, if you don't have the salts out here, and let's say it's 900, now the most concentrated your urine could be would be 900 milliosmoles. So what it does is it interferes with the salts, creating that hypertonic interstitial medulla, and then that's why you lose more water when you're on them. And there's other types of diuretics. I just want to mention that specific one. An osmotic diuretic is something that creates osmotic pressure. So it's something in the filtrate that's not supposed to be there. It's normally not there. And a good example is glucose. And so what happens is if you were to have more glucose in your filtrate, so actually let me show you, let's go back to just the general nephron picture here. We know that in the PCT, all that glucose is supposed to leave. It's supposed to be reabsorbed and go back into the blood. Well, what if you had high glucose in your blood, so you exceeded your renal threshold? Well, all that glucose would stay in the filtrate, and now you would have a lot of glucose in your filtrate, so it would actually increase the osmolarity of the filtrate. So now maybe the filtrate is 600, right? So you're changing the actual filtrate. Well, what that does is that pulls water toward it, because water just goes. Whether there's a higher osmolarity, it can't be pumped. So if you have more solutes, that's going to pull water toward it. So now you're going to pull water into the filtrate, and you're going to increase a lot more urine. In fact, when we look at type 2 diabetes and type 1 diabetes mellitus, a lot of times you will have what's called polyuria. You'll have a large urine output, and then often you have excessive thirst because you're losing so much water. And one of the signs is having to wake up during the night and urinate frequently. Now, other things that work like a diuretic are things that increase urine output. So it could also be things that, like osmotic diuretics we mentioned, but alcohol is a diuretic because it actually inhibits ADH. So when you drink alcohol, especially if it's like a watery beer, you have the water, you inhibit the ADH, and now you have a very dilute urine. So you pee a lot, and you pee a lot more, and you get dehydrated, and that's why you get a hangover. We also know caffeine is a diuretic, and the way caffeine works is it increases GFR. So if this flow is too fast, remember you're going to lose more things than you wanted to, and so everything moves quickly through it, including water. And so you will have a larger urine output as well. And so, if you're outside exercising or working on a hot day, you probably don't want to drink a lot of caffeine. You'll get dehydrated faster. And as we mentioned on the previous slide, a lot of diuretics are given to help with congestive heart failure and edema, and basically help to increase urine output. Now, there's something called renal clearance I want to mention. A renal clearance test is a test done to assess kidney function. So a lot of times it's calculated or estimated with formulas, but they're trying to see that glomerular filtration rate. And so it really depends on how much of the material is in your blood, your GFR. The magic number is 125 mLs per minute. That's your typical normal rate. And so we do this to calculate it. So one thing they might do is called a creatine clearance test. And again, they can estimate the GFR, or they will use something called inulin. Now, it's not a typo. It's not meant to be. It's inulin. And inulin, they can give it to you in an IV. It's not metabolized, so your body doesn't make it. So it's not metabolized. It's not broken down. It's not reabsorbed. So what goes in should come out. So it would give you your GFR of 125 mLs per minute. So you would see that it was normal. So a lot of times what they can do is estimate GFR. And if we know, 125 mLs per minute is the rate, then if you're looking at the renal clearance, if it's not 125 mLs per minute, right? If 125 mLs doesn't come out, where did it go? Well, some of it got reabsorbed. If it's 0, then none of it came out, because clearance is what comes out. How much do the kidneys clear? Then it was completely reabsorbed. And if it was more than 125, if you only brought 125 into the kidney, but you're excreting more, then some of it was actually secreted by your blood. So this might make sense when we look at some numbers. So the renal clearance of urea is 70. So what that means is that 70 is cleared. 70 leaves the body, which means that you reabsorb approximately 55, because remember the normal rate is 125. And again, we know that we reabsorb urea in our collecting duct, right? That urea leaves to concentrate the filtrate. If we look at it for sodium, it's only 0.9. So, you reabsorb like 99% of all the sodium is typically reabsorbed, right? We take the difference. The amount cleared is what hits the toilet. Think of it that way. And so we reabsorb a lot of it, and we release aldosterone all the time. Notice creatinine, it's a waste product, so we actively secrete it. And the renal clearance of glucose should be 0, right? All the glucose should be reabsorbed unless you exceed that renal threshold. So that's what the renal clearance test means. Now, if we look at urine, which we'll be doing in lab, we know that urine depends on the movement of water, right? It's a lot of water. It's about 95% water. It is clear. It should be clear. You should be able to see through it. It's sterile. There shouldn't be bacteria in it. Technically, you could drink it. If you're out in the middle of the desert, you have no water, you could probably drink it once, maybe twice before it's become too toxic. It does have a yellowish color to it from urobilin. You might remember that's from the kidney, from when we break down that the hemoglobin went to bilirubin, and some of it came out in the urine. If we were to look at typical color of urine, and this is just more like an FYI, but one thing I would like you to know is that the color can give you some information. If it has like a reddish color, that's usually blood. Now, if you ate a lot of beets the night before, maybe, but it's usually blood in it, which could be caused by bleeding in the urinary tract. It's usually some form of yellow. The lighter it is, the better. That means it's more watery. As it gets darker and darker, it has less water, so you're much more dehydrated if it's like a darker yellow. And then some of the other colors can indicate issues with the liver, but we're not going to get into it to that level. When we look at it, we know that the volume of it is roughly, now this depends on what you drink, usually 1.5 liters per day. If you drink a lot of water a day, which you should be doing, you're going to pee more, and that's fine. So we worry more about oliguria. If you're urinating less than 500 mLs a day, it's not good. It's usually a sign of obviously something wrong with your kidneys. Polyuria is a larger urine output, but again, that could be just based on what you drink. Notice there's a wide difference in pH. If you eat a more plant-based diet, they tend to be more alkaline foods, so your urine might be a little more alkaline. If you have a really high protein diet, it might be a little acidic. And the specific gravity is just looking at the density of urine compared to water. The specific gravity of water is 1.00, and just notice urine is just slightly higher, and that's just representing that there's stuff in your urine. There could be cells in your urine, obviously there's waste products in your urine. The more stuff in your pee, the higher the specific gravity. It also shows how concentrated it is. So if you have very dilute urine, if you have a lot of this watery urine, then that's good, right? Because that's what we want. The specific gravity will be less, but as we have more concentrated urine, our specific gravity is going to go up. So urinalysis is taking a urine sample and testing it, and it is a really good, important diagnostic tool. It gives us information about our kidney function, and we know that urine should have urea, creatinine, and uric acid, and it has some electrolytes. When you do a urinalysis test, what you do is, I call these things these little dipsticks. So we have these little blocks. You dip it into your urine sample, so you saturate each block, and then you just line it up and you match it to the color to tell what is present in the urine sample. The lower block here, this aqua one, is glucose, and so you would just hold that over, and then you would be able to record your value, and you just work your way up block by block. We always start at glucose because leukocytes take the longest to record. And so it's a good way to measure the presence of different substances in your urine. So you have this table in your notes, and you don't have to memorize everything, but we went over normal urine. Notice it's sterile. There shouldn't be bacteria in it. You shouldn't have cells in it. You shouldn't have red blood cells or white blood cells in it. If we look at the chemistry, shouldn't have glucose. You might have a little bit of sodium, and you always have some potassium. We talked about that. You lose 10 to 15% per day. And if we know what shouldn't be there, and then we find things in it, it helps us diagnose disease. Now, you also do blood work when you're looking at kidney disease. So these are blood values, BUN, blood, urea, nitrogen. It's how much urea and nitrogen is in your blood. There shouldn't be a lot because your kidneys are getting rid of it. Same with creatinine, the waste product, and potassium. Notice all of these go up if we have issues with our kidneys because our kidneys aren't eliminating those wastes. So we look at what's typically found there. We know that, if you have a higher number of leukocytes, that usually indicates an infection. So it could be a UTI. In your handout, you have the term pyuria, and that just means pus in the urine, which is having leukocytes, because leukocytes make the pus. Remember, they eat everything up and they pop, and that's what pus is. So pyuria could be a UTI, a kidney infection, something going on. Now, the other ones I want you to know is we're not worrying too much about the nitrates and the urobilin. There could be some issues. But if we look at protein, you can have protein in your urine, proteinuria, and that typically indicates a kidney disease, because remember, if you have holes in the membrane, the protein is going to get out, so we don't want those to get out. We talked about blood a little bit. Usually it's some kind of bleeding in your urinary tract. Ketones, now ketones are produced anytime we're burning fat at a high rate, so we either are on a low carb diet, or we're not eating at all, we're starving, or we have diabetes, mellitus, and we can't use the glucose, so we make all those ketones as well. And then glucose, again, commonly with diabetes mellitus. Bilirubin should not be in your urine. If it is, it shows probably something with your liver. And the other thing to understand is that anytime you're dehydrated, all of these values go up. Here's a little table going over some of the abnormal components of urine. Again, glucose would be glycosuria, typically a sign of diabetes mellitus. Technically, if you had a huge intake of sugary foods right before your blood test, your blood glucose could be elevated. Your protein, either proteinuria, also known as albuminuria, typically due to kidney disease. Hypertension could cause it because you're increasing that hydrostatic pressure and forcing more fluid. You could have protein in your urine if you're pregnant, or extreme physical exertion. If you ran a marathon the next day, you would probably have protein in your urine. We mentioned the pus and the white blood cells. Red blood cells, hematuria, typically due to bleeding or trauma or infection. Hemoglobin also should not be in your urine. Remember, this is that hemolytic anemia when the red cells are lysed too quickly, or if we see bile, we're going to worry about liver disease. The test we do to assess kidney function when we analyze the blood. A BUN is just literally the amount of urea and nitrogen in your blood. We're not memorizing the number, just know if it goes up, it shows that there's some kind of thing going on in your kidneys. Sometimes they might go up, maybe you're on a really strong antibiotic or certain medication, and it's a temporary thing. And then they also look at your creatine levels, and we know that those should be pretty low. Again, just know as the numbers go up, it's showing renal failure, and same with potassium. Because the kidneys clear 10 to 15% of the potassium every day. If the potassium levels go up, that's a sign that your kidneys aren't working real well. So we look at some of the clinical things. The first one are kidney stones, and you can see you actually get these deposits. A lot of times they can be from like calcium or uric acid, but you get the urine crystallizes. So one way to help prevent them is to drink lots of water. Stay hydrated, because you're more likely to have these things crystallize when you have dehydration and you have more concentrated urine. So they're going to hurt. They can clog up a ureter. They can cause urine to back up into the kidney, which is not good. It's called hydronephrosis. And these stones can block the passage of urine, and so it's painful. A lot of times they're from calcium, so you might want to decrease your calcium intake if you're prone to having kidney stones. And, you know, the pain is pretty bad. It might make you vomit because the pain is so bad, but classically blood in the urine, because these stones are cutting into things, and so you're going to have bleeding. They can see them on an x-ray, they can do a CT scan, and they can see the stones. You can pass the stone and see it. A lot of times they can give medication, like basically to open up the ureter. So they might be an alpha blocker, because if you block the alpha receptor, it causes, instead of vasodilation, it makes all smooth muscle open up, and the ureter has a lot of smooth muscle, and the urethra. Sometimes they'll do surgery. They can put like a stent in, or lithotripsy uses ultrasound. So they use ultrasound, and it pulverizes these stones into smaller pieces so they can pass. And the idea is lots of water, less caffeine, less dark sodas, and there's some evidence that increasing citric acid and citrate helps prevent these stones from forming. Now, you can have all different types of infections in your kidney, in your ureters and urethra and urinary bladder. So UTIs, they're usually bacterial or fungal. We see these more commonly in women. For one thing, the urethra is much shorter. It's near the anus, so proper hygiene. If you have a bowel movement, make sure that you clean yourself front to back instead of back to front. You could introduce feces. It has a lot of bacteria. You might remember that's mostly bacteria. So you could introduce bacteria. Intercourse can push it up, so urinate after intercourse. And we know bacteria replicate really, really fast. So really important, don't hold your pee. When you gotta go, just go as well. And then some other terms, urethritis is in the urethra, cystitis is when it's in the bladder. They're going to have typically painful, burning urination. As I mentioned, you would have a high leukocyte count in your urine. And so the treatment is to get on either the antibiotic or the antifungal, depending on what's causing it. Glomerulonephritis is an infection in the glomerulus. We talked about the glomerulus and the glomerular capsule. So this is actually up in the filtration area. It can be acute. Now, one thing that happens is a strep infection. If you have an untreated infection, streptococcal bacterial infection, you're going to make antibodies against it. So these immune complexes, those antibodies bind to the antigen, and they can get stuck inside the glomerulus, and they can damage the basement membrane. So they actually have damage in the glomerulus. So any bacterial infection can cause it, viral infections can cause it, and sometimes you'll see it with lupus, which is an autoimmune disease, so you have a lot of those complexes. So, the treatment of it is going to depend on what's causing it. If it's bacterial, you'll go on antibiotics, probably IV antibiotics. If it's an autoimmune thing, they might do corticosteroids to suppress your immune system. They can do plasmapheresis, where they basically filter your plasma and get those antibody antigen complexes out of there, so they stop plugging up the glomerulus. Or in extreme cases, you could go on short-term dialysis where you basically are hooked up to an artificial kidney. So if you have glomerulonephritis, often you'll have some blood in your urine, definitely protein in the urine. And when you have protein, a lot of protein in urine, it makes it look foamy. If you ever beaten an egg white, you get a little foam. So that's from the albumin, the protein. You're going to have edema because your kidneys, the filtration membrane's blocked. So you're not able to eliminate the waste, so they're going to back up, which would mean that your blood pressure probably goes up. You're going to be tired from all those wastes accumulating, so your BUN and creatine levels are up, and you're peeing less. So again, if they can figure out the cause, you can get treatment, and it will clear up. It will heal. Chronic, that's harder because when you see chronic, you know this is a longer term thing happening. This could happen from high cholesterol levels, basically damaging the glomerulus, all those lipids. Diabetes mellitus, type 1 or type 2, and lupus can cause the chronic one as well. Or you don't treat the acute one. Once you see the chronic, that's never good. Those are irreversible. So once they catch it, you've done too much damage, so it's going to affect you permanently. And then typically these slowly progress into a more severe kidney disease. So when we're looking at renal failure, you know, the kidneys can't do what they're supposed to do. So we're looking at a problem with our fluid balance, our pH, muscle contraction because the electrolytes are off, we have too much waste, so very, very serious. And when you're going to renal failure, your BUN and your creatine go up, and the worse it is, the less you pee. So the liguria is as the kidneys are slowly failing and not working as well. So all that water goes back in your blood, you get hypertension, the kidneys make EPO, so now you're not making EPO, so your hematocrit falls, and as you increase all those wastes in your blood, it affects your brain. So a lot of times it can make the person really sleepy. They could have seizures or even go into a coma from renal failure. Now there's acute and there's chronic. So again, acute, same thing. Acute is short term, more sudden onset. And it could be maybe there was a problem, a blood flow issue. So you had some ischemia and then they correct the blood flow and it's going to heal. Or an obstruction, maybe of that hydronephrosis where the urine backed up in the kidney and damaged it. Certain drugs could do this as well. So what's going to happen is you have a problem with kidney function and you go on dialysis, and if they figure out the cause and they fix it, then they usually regain their function. They might not regain complete function. It depends on how long the problem went on, but they can regain function. If it's chronic, this is the problem. As slowly over time, the kidneys, gradually start to deteriorate. If someone has unmanaged type 2 diabetes for years and years and years, it can send them into chronic renal failure. This is irreversible, and they go into what's called end-stage renal failure when the kidneys are down to less than 10%. So in someone with chronic renal failure, their kidneys aren't going to work. They're going to have dialysis, and they're going to need a kidney transplant. And dialysis is basically a machine that works like a kidney. So a former student took a picture of this from work. She worked as a tech, and this is an individual undergoing dialysis. So it takes their blood, runs them through the machine, and it works like a kidney. It sorts it all out so that it can send the good stuff back into the patient and try to remove the waste. And depending on how bad the kidney is, you might have to go every day at the end, unfortunately. And if you can't get a kidney, then, unfortunately, people do succumb to this. And then just to wrap up with our aging slide, just as we get older, we're going to lose our nephrons. Our kidney function's ultimately going to slow down as we get older. It's just what happens. We'll be a little less sensitive to ADH, so we really want to watch our water intake and our water balance. And then you might have a problem with your micturition, your urination, right? You might have some incontinence with aging. So this wraps up the urinary system.